Hello everyone, welcome to our briefing. I'm Brian Huddage with the National Coalition for LGBT Health and also the Executive Director of Health HIV, which manages the coalition. And I'd like to welcome you to our briefing this afternoon. Timing-wise, I know that this was a challenge with a lot of other activities and a lot of people going out of town and so forth, so we will try to stay as on time as possible so that people can get to other things as well. I also want to mention that we are videotaping because there were a number of people that wanted to attend today, but were at other meetings, and so we'll be able to share the video and we'll put that on our site as well. I also want to mention that we are celebrating, and we are in the middle of National LGBT Health Awareness Week. As you can see here, and the theme this year is Time to Come Together, Trust, Transparency, Truth. And I wanted to just give you a quick background about the theme as it sets up the scope of our briefing today. LGBT Health Awareness Week was created by the Coalition in 2003, and the purpose is to promote increased health awareness and outcomes in the LGBT community and the need for cultural competency in the healthcare system. And certainly those will be themes within the discussion today. The Coalition's members informed the theme and the scope of our activities this week. And what was interesting is as we compiled the survey results, what came to light, as it turned out, were three words that began with a T that were the themes that were consistent through it. And I'll be detailing that in a moment. Importantly, it's not just an awareness week like every other awareness week, that it's a week and it's awareness and it comes and it goes and say la vie. We really want this to be setting the stage for a year's worth of engagement in the three T areas: trust, transparency, and truth, and aligning that with the three activities of the coalition: advocacy, education, and health services research. So this is really the kickoff point to a year's worth of activities stemming from the themes from an awareness week. And so I think that's really important in that we want to focus on health outcomes in every regard, including when we're conducting awareness efforts, and can connect it to meaningful activity throughout the year. So along the lines of the theme, it starts by saying it's time to come together. And that's the beauty of the coalition, is that it represents LGBT providers, LGBT health centers, LGBT organizations, LGBT consumers, and others interested in LGBT health. And so the idea that, especially at this time, there's always a good time to come together, but I think especially at this time that we're kind of taking a somewhat of a collective breath of where we are with the ACA and where we are with a variety of efforts that impact the LGBT community in and outside of its healthcare. And then specifically the three T words: time to build more trust with providers, among providers, and in the healthcare system. Not just in regards to culturally competent care, but just in trust in having discussions about LGBT health needs, about sexual health, and so on and so forth. Also, it's time for transparency in the system, advocating for authentic and complete data collection of sexual orientation and gender identity to reflect reality. And hence the theme of today's briefing, focus on transparency, and the time to tell the truth, being honest about our orientation, gender identity, our health needs, and the engagement with providers and the health system overall. And so today's briefing focuses on it's time for health transparency. So transparency defined in a variety of ways, starting with data collection, and Leo Katari will be speaking to that. Kevin Cranston will discuss transparent public health systems. Alison Gill will speak about transparent health funding. And Nick Martin will be speaking about transparent government programs, and Christopher Cannon about transparent research. And so we have our terrific panel with us today, and we will have questions at the end. And so that we can stay on schedule, I will move right into introducing Leo. who works for One Colorado and is a health policy manager. And I also want to note there's some terrific One Colorado material on the table outside of the meeting today. So, Leo, welcome.
Good afternoon, everyone, and I want to just start off by thanking the National Coalition for LGBT Health for hosting this amazing event and really highlighting the importance of LGBT health across the country. I'm Leo Katari, the Health Policy Manager for One Colorado. And One Colorado is Colorado's leading advocacy organization for lesbian, gay, bisexual, and transgender Coloradans and their families. And I'm here to speak to the importance and the dire need for transparency and data collection that better represents LGBT communities across America. And while data and research might be mundane and boring to some, data tells a really critical story and narrative that identifies communities most at risk for health disparities. Data informs funding priorities for government agencies, foundations, and private funders, and it also drives policy change at local, state, and national levels. In my position at One Colorado, data is the pillar to advancing the health of LGBT Coloradans as well as all Coloradans. However, data collection for LGBT communities is subpar across the country, even though we know that the LGBT community faces higher rates of health disparities. Few states across the country offer the option to collect information on sexual orientation and gender identity to track health outcomes, leaving this imperative work to nonprofits like One Colorado. This leads to inconsistent data on LGBT health as different collection tools and instruments are used in different cities, different states, and across the different regions. And this data is then incomparable state by state, and then we can't compare the data of LGBT health to the general population at state levels or national levels. This lack of transparency in data collection extends to the federal government as well. While we've seen some strides by agencies like the Centers for Disease Control, that they validate and offer options for states to choose to include questions on sexual orientation and gender identity, most states choose not to include these questions on their surveys, especially questions around gender identity. So for the most part, we're left in the dark about the healthcare experiences of transgender Americans, transgender folks like myself. And as an organization that works to improve policy, including healthcare policy, One Colorado had no choice but to develop surveys and conduct our own research to really better understand the needs of LGBT Coloradans. In 2011, we released the Invisible Report that surveyed LGBT Coloradans about their experiences in healthcare coverage, experiences, and what their needs are. The Invisible Report found that a strong majority of LGBT Coloradans face challenges to accessing affordable and quality health coverage, with 15% of LGBT people of color and 27% of transgender people reporting having no health insurance at all. Shockingly, 55% of LGBT Coloradans feared being discriminated against while accessing care, leading to 28% of LGBT and 61% of transgender people refusing to care or not seeking out care they need because of this fear. To follow up on the Invisible Report, One Colorado surveyed Colorado physicians to see what their perceptions are working with LGBT patients. And so in 2013, we released another report called Becoming Visible. We love the word visible and invisible, it's just what we do, and transparency. And this report found that a strong majority of Colorado physicians report being comfortable treating the LGBT community. Now this fact contradicts what the Invisible Report said, where majority of LGBT Coloradans fear going to the doctor and seeing their physicians. So we need to address this gap in perceptions between providers and LGBT people. And one way we can do this is by ensuring physicians are comfortable asking their patients about their sexual orientation and gender identity. The Becoming Visible Report found that this is currently not the case. And without this important information about their patients, physicians are not going to be able to provide the best and most adequate care for each individual patient that they serve. Then in November 2014, One Colorado was the first state to conduct a statewide survey on transgender health. In developing this survey, we intentionally used questions from the CDC's Behavioral Risk Factor Surveillance System, or the acronym is BRFIS, so that we can compare the health of transgender Coloradans to the general population of Colorado, and so that other states can also replicate this survey and do the same. This groundbreaking report, Transparent, the State of Transgender Health in Colorado, found that transgender Coloradans greatly benefited from the implementation of the Affordable Care Act, and specifically the expansion of Medicaid in Colorado, with about 20% of transgender Coloradans being covered by Medicaid, compared to about 7% of the general population in Colorado. Transparent also found that the transgender community experiences greater mental health disparities compared to the general population, with transgender Coloradans being 9 times more likely to contemplate suicide and 10 times more likely to attempt suicide in the past year. And at this point, it's really important to note that these mental health disparities that transgender people experience are not because of their gender identity, but because of the daily experiences of bias, stigma, and shame and discrimination that transgender people experience. And an example of this discrimination is our transparent report found that transgender Coloradans are twice as likely to have a college degree, yet they're also twice as likely to be unemployed or twice as likely to be underemployed, making $50,000 or less. So another significant finding in the transparent report is that having a transgender-friendly provider greatly impacts a transgender person's overall health and well-being. So physical health, mental health, and access to the services and resources within healthcare as well as outside of healthcare. And so this data that we collect informs our policy work and helps us identify where we need to go, what policies we need to shift. So through this data that we have, we were able to work with the Colorado Division of Insurance to release a bulletin that prohibits private insurance plans sold in Colorado from discriminating against LGBT people. This means that being LGBT can no longer be considered a pre-existing condition, or that LGBT people cannot be charged high premiums, and insurance companies in Colorado cannot deny transgender people medically necessary care like hormones and surgeries. One Colorado has also been able to build a relationship with the Colorado Department of Public Health and Environment. CDPHE is our health department. We love our long names and acronyms. And we've been able to work with them to make sure that sexual orientation and gender identity questions are included in our state BRFIS, as well as its youth counterpart, the Youth Risk Behavior Survey, or the YRBS. The data collected through the BRFIS is used to inform funding priorities for state agencies like the Public Health Department, like Health and Human Services, and our Medicaid office, which is the Department of Healthcare Finance and Policy. Also, our state foundations that fund healthcare programs use the BRFIS data to determine who they're going to fund. So the Colorado BRFIS has included a question about sexual orientation since 2006, which is pretty impressive, and we're one of the first states to do so. And by having that information, we were able to track that lesbian, gay, and bisexual people in Colorado are at a higher risk of heart disease, cancers, and tobacco use. However, they've never asked about gender identity. So in Colorado, we don't, other than the transparent report that One Colorado did, we don't have that information on the transgender community. However, in 2015, CDPHE will be adding a gender identity question to the BRFIS, and we're going to be one of the few states who do so. The Healthy Kids Colorado Survey, which is Colorado's YRBS, tracks health outcomes of young people in multiple areas like bullying, substance abuse, as well as mental health. And in 2013, the Healthy Kids Colorado Survey received over 40,000 responses. So now for all the data nerds in the room like me, that is a huge response rate, 40,000. And so in 2013, they had a question that asked about sexual orientation, and we had a big enough sample size to really be able to pull out what the experiences of LGBT youth look like. However, they did not ask about gender identity, so we're still pretty clueless about what the experiences of transgender youth are in Colorado. We're also pretty clueless about those experiences for transgender youth across the country. And so I cannot emphasize the importance and need of transparency and data collection for LGBT community. Report after report really shows that LGBT communities are experiencing higher rates of health disparities, especially LGBT people of color and transgender people. Yet we still don't have a uniform way of tracking this data so that we can better address these health disparities. We can do better in advancing LGBT health in the United States, and one way that we can do this is by requiring federal agencies to include questions about sexual orientation and gender identity in all surveys and in all research, within healthcare but also without, like the census data as well. We also must require and hold agencies and organizations that receive federal funding accountable to serving the LGBT community. rather than allowing these organizations to continue to discount the experiences of LGBT people who use their services. Lastly, the Centers for Medicare and Medicaid are releasing new standards for meaningful use of electronic health records. Fancy way of just saying this is how you use electronic health records. For hundreds of thousands of hospitals, healthcare clinics, and providers across the nation. And this is the opportunity to ensure that electronic health records accurately represent sexual orientation and gender identity so that providers can feel more comfortable asking those questions. And then ultimately, providers will feel that will be able to provide better care. I also want to address one of the most common questions I get around asking about transgender people and gender identity. In One Colorado and many organizations across the country recommend a two-tiered question. One is asking sex assigned at birth and having a binary answer, and the second part is asking for current gender identity and having multiple options that people can fill in, including a blank space. And this is a non-invasive and optional way for transgender people to identify themselves. In closing, asking questions about sexual orientation and gender identity to the general public is not harmful. On the contrary, it provides an opportunity for individuals to accurately describe themselves. A 2014 report released by the Fenway Institute, a well-respected medical institute, found that a strong majority of people across all demographics see value in, understand, and will openly answer questions about sexual orientation and gender identity, regardless of how they identify themselves. So we cannot wait any longer for transparency in data collection. And I ask all of you in this room right now to commit to ensuring all Americans have the opportunity to live their lives openly, honestly, and with the health and happiness we all deserve by making LGBT health, and especially LGBT data collection, a priority right now. Thank you very much for your time.
I'm not screwing it up if I do that. Okay. And being a man of a certain age, sorry, this as well and blow it all up really big here. Hi, I'm Kevin Cranston. I'm the Director of the Bureau of Infectious Disease at the Massachusetts Department of Public Health. I also happen to be a member of the board of Health HIV, and I just really want to again appreciate the Brian and the staff and board of Health HIV for welcoming the National Coalition for LGBT Health into their fold. As you may know, I'm a member of the former board of the coalition, and in that period of interruption, it was really Health HIV that stepped up to the plate and created a home that allows not only the coalition's work to continue, but today's briefing to go forward. So thank you very much, Brian, and everyone there. So I'm really proud to live in the first health reform state, the first state to have legal same-sex marriage. I'm proud to have grown up out and proud. I've been an out gay man since my high school years, and to have done so in a reasonably safe environment. Massachusetts has been my home since I was 18 years old. And actually to be able to have a career as a transparently out gay man across Republican and Democratic administrations in state government, and frankly to see the fruits in state government and in social change of our early LGBT activism. And I'm proud to have a little small role in some of that. But I'm really looking forward to the day when Massachusetts is not at the vanguard of healthcare reform or of so-called gay marriage, that these become the standard for the United States, standard for all residents of this country, and that all residents of the U.S. have equitable access to primary and specialty care, preventive health services, can live out as trans and queer folks, and enjoy the benefits of a just democratic society free of fear and intimidation. Still looking forward to that. So thank you very much, Leo, for talking about data collection. We in public health live and die on our data and thrive on it when it's there. And so I want to just reiterate some of your action points, because I think it is really incumbent upon all of us, and it's your bullet point around data drive policy. Data drive funding, of course, but policy is just as critical. We don't do things that we don't see, we don't respond to things that we don't see. So it's absolutely essential, as you said, to make LGBT identity and part and behavior standard data elements in our disease epidemiology in our behavioral and other population studies like the BERFIS, like the Youth Behavior Survey, and also in other public health and health services program data collection. Because it's not enough to identify the health risks, we have to really demonstrate that our funded programs and our social policies are actually responding to those health risks. And that's the accountability, that's the transparency feedback loop to the risks that are identified in our population studies. We can't assess disparate risk or track our success in addressing these issues without high quality, standardized, and longitudinally collected health data. It's not enough to do these convenient sample studies. This needs to be built into the fabric of our public health and healthcare programming. How we present the data also matters. We really do need reliable population estimates of the size of the lesbian, gay, bisexual, and transgender communities and subsets of those communities. We continually run into what we call the denominator problem in public health, because when you're comparing two populations of different size, we often resort to the case rate approach. You can only establish a case rate for a particular issue, health outcome, if you know the denominator, if you know how many gay men, lesbian women, bisexual individuals, transgender men and women there are in the population. So we continue to need, not only at the national level, but at our local level, at our state level, reliable population estimates and then we can start to really see the differentiation. I want to highlight the importance of vital records. It's a part of public health that most folks don't think about, our birth, death, and marriage records. But in fact, they're deeply problematic, particularly for the transgender community. We have in Massachusetts, just in the last year, as ahead of the game as we feel we are, it's only been in the last year that we have streamlined the ability of individuals to change their birth record. It used to be an unbelievably torturous process involving court appearances and extraordinary resources. We've made it a more simple administrative process, but we have yet to do that on the other side. We still have challenges for individuals who have reassigned their sex legally, still being counted often by their family or by the medical examiner by their assigned sex at birth. So we still have work to do in terms of all of our vital record efforts. We need to, as I said, move beyond convenience samples, and we need broad incidence data to be able to estimate both the prevalence and compare case rates of other populations. An example of that, I come out of the HIV world. I did most of my career in public health in HIV, and now I do broader public health, broader infectious disease work. For many, many years, we have calculated appropriately and highlighted appropriately the disproportionate and tragic impact of HIV infection on Black and Latino populations. In Massachusetts, the prevalence of HIV amongst the African American and other Black communities is 10 times that of white populations, and amongst Latinos about 8 times that. But because we didn't have the denominator for years, until we had the BRFSS or BERFIS data to make some reliable estimates about the size of the MSM population, okay, now, men who have sex with men in the past 12 months, regardless of how they identified. We've identified now that the prevalence of HIV amongst men who have sex with men compared to those men who have not had sex with men in the past year, and that's just a behavioral comparison, is 24-fold. It is actually the largest single disparity of HIV infection and prevalence in our state, and yet went unreported throughout the almost 30 years of the epidemic until we had the reliable population data. Okay, so that's my data piece. I just want to reiterate that because I think it's critical. The data have driven policy and they've driven approaches to our work. We actually added same-sex sexual behavior to our Youth Behavior Survey in the early 90s. I was very proud to have worked in the Department of Education in Massachusetts at that time, and I had a narrow political opportunity to get a couple of questions on. But it highlighted the disproportionate impacts of a variety of health issues, suicidality really jumping out of the data set, that established at that time a governance commission on LGBT youth. Then we had another governor that didn't want to be associated with it, and then we had the legislature establish the Massachusetts Commission on LGBT youth. And so that's for over 2 decades. We've had an official panel of state government advising a variety of state government entities and drawing our attention to the disproportionate risk and the opportunities for health and well-being amongst the youth population. I'm also proud to be part of what we believe is the first state-level commission on LGBT and aging. And so we're just about to issue our report next month. These bodies focus on and collect data as well as anecdotal experiences and make recommendations to state government. But they provide a crystallizing framework for future action, governmental action, and is an example of the transparency that we're trying to advance today. So healthcare reform. What we know about LGBT health disparities from the data sets we have in hand they're extremely well documented, and I particularly want to highlight some of the work of Carol Goodnow, Stuart Landers, and Gareth Conran, who have published extensively from our data sets and have taken the time to do that, have demonstrated higher rates of HIV and syphilis amongst men who have sex with men. Trans men and trans women have severe health access challenges, as you mentioned, Leo, often linked to employment status. That comes out loud and clear in our data sets. There's an emerging data set around lesbians and cancer risk, cardiovascular disease, diabetes, possibly related to or maybe coexisting with higher rates of obesity among some lesbian communities. And then all LGBT community members appear to have higher rates of violent victimization, substance use and abuse, suicidality, and other mental health issues. And amazingly, this is one I wouldn't have predicted, asthma. Asthma is higher amongst LGBT community members in Massachusetts than in the general population for reasons that are not fully understood. But that's what public health does. It finds things and then finds the reasons for them, and then we try to go upstream and address those issues. So Massachusetts began its long road, which it's still on, in establishing healthcare reform back in 2006 with Chapter 58. And this was the model for the ACA. So if you know the ACA well, you know most of what the Massachusetts healthcare reform process tried to put in place. Of course, it focused on coverage. It tried to address the underserved, the historically underserved members of the population. We did expand Medicaid to achieve some of these outcomes. We're trying to establish adequate primary care, early detection of disease risk and diseases themselves, and have the opportunity for vigorous intervention on health problems. That's what health reform in part is trying to do. But we're also trying to not just expand coverage, but improve long-term health outcomes. And frankly, trying to contain and even reduce the growth of healthcare costs. That's all part of the healthcare equation. So our healthcare process has continued with Chapter 224, which is introducing global healthcare payments, accountable care organization structures, and trying to advance a whole person approach to health promotion and prevention. That way, we're really trying to go upstream, not just in public health, but in healthcare delivery. This is relevant to the LGBT community. We have established in law, and thankfully in parallel in federal law, mental health and substance abuse parity, because so many medical issues are related to substance abuse and mental health challenges that were under responded to in our former healthcare system. And finally, need to advance more aggressive screening and referral and patient education, treatment engagement, follow-up, and medical management of selected conditions. So that's for everybody in Massachusetts, but has particular value for members of the LGBT community. So LGBT health is not just about HIV and STDs anymore. And we're advancing our work in our health department in the areas of substance abuse with specialized prevention and treatment programs for the LGBT community, and much greater improvements in program data collection and expectations on the part not only of those specialized programs, but of all programs to show that they're equitably serving members of the LGBT community. Our violence prevention efforts have grown immensely around the LGBT response. Sexual and domestic violence, homophobic and transphobic violent victimization, and frankly trying to improve the reporting and the criminal justice response, reporting by victims and response by criminal justice to violent victimization. I have a little more to say about primary care and chronic disease, which is just inching into this area in our health department. But we have established in our department a broad response to health equity. So we see health equity as a fundamental challenge of public health, and have added to our health equity, Office of Health Equity, LGBT community liaison, full-time liaison. Some of you may know Barry Callis, who's worked in the HIV field for many years, who now is our publicly identified LGBT liaison. So a word or two just about primary care. This is where I think a lot of the action is in healthcare reform and in transparent systems. that we need to address issues of access. We need to make the environments that LGBT individuals go to feel welcoming and respond and signal to individuals from the first engagement on the phone or to the enrollment process to the review of insurance status to the clinical encounter, that this is a welcoming and responsive and knowledgeable place. We first of all need to make sure there's adequate network coverage, particularly of some of the specializations that LGBT individuals may need. There's a lot of work being done locally and nationally on the training of primary care providers about how to create those clinical environments. Fenway Health, you mentioned Fenway Institute, this is our premier LGBT health center in Boston. My neighbor, I live right around the corner, has a national contract with HRSA to advance some of this primary care training. To make sure the adequate and appropriate screening for sexual risk, smoking, diet, cardiovascular risk, violence are occurring in the primary care encounter and in a way that's informed by knowledge of those disproportionate risks faced by some members of our community. That we need sensitive and responsive care for trans men and trans women across the system, as well as specialized providers who really can do the deep dive around some of those challenges and issues that an individual may be facing. And frankly, I need to reiterate that if we haven't done our job on HIV yet and gay men, particularly on gay men of color, HIV-positive gay men in particular need lifelong primary care. Many have started their health care in an infectious disease practice and are now aging. 57% of men with HIV in Massachusetts are over the age of 50. And so are dealing with the issues of middle age and later age and actually need primary care to address those broader issues. Chronic disease is just waking up to this in our state and I think nationwide. I think the lack of proper screening historically that's occurred for our community has resulted in higher rates of overweight and obesity, diabetes, other metabolic issues, cardiovascular disease, cancer risk, and for some reason asthma. My own program, which manages the immunization response, has really woken up to the fact that they need to do some specialized work to make sure that sexually active gay men are adequately immunized against hepatitis A and hepatitis B. That human papillomavirus is made available to all members, particularly the youngest members of our community, as they anticipate sexual lives that may not be fully predictable. And older LGBT individuals may have, because of their primary care lacks, not have enough vaccination against the flu, pneumococcal disease, herpes zoster. There's work to be done, which are issues, are age-specific issues, but may have particular challenges in our community. And I'm delighted to say that our maternal and child health, which is the language that we use, the maternal child health programming are waking up to the fact that gay men, lesbian women, and transgender individuals are parenting and, parenting biologically, parenting through adoption, parenting through foster care, often taking on the kids with the greatest special health care needs. And almost no one's talking about LGBT issues in that context, and they're really beginning to wake up to that reality. It's actually parents that have brought that forward to them. So just a couple of special learnings that I want to leave you with as a last comment. Marriage and Medicaid expansion make a difference for our community, and I really appreciate you highlighting both of these. The greatest increase in healthcare coverage for the LGBT community occurred following the approval by our Supreme Court of same-sex marriage. Most insurance is employment-based, and people were not getting the benefit of their partners, now spouses, health insurance until they were legally married. It's a discernible difference in the coverage of our community. And we all need to be part of advancing Medicaid expansion. Not all LGBT individuals are rich. Many are not even middle class. There's a lot of poor LGBT folks in this country, and Medicaid is their health care system, is their health insurance system. If we don't expand Medicaid, we're going to miss the boat for our community. The Supreme Court decisions in both these areas are going to be key, and I have fingers and toes crossed. Thank you very much for your time and attention.
Alison Gill, who's the Senior Legislative Counsel of the Human Rights Campaign, talking about transparent health funding.
Thank you. Hi everyone, I'm Alison Gill. So I'm going to be talking about transparent health funding in the context of conversion therapy. Who's heard of conversion therapy? Okay, so most people, great. So let's define conversion therapy first. Conversion therapy are practices that purport to either change a person's sexual orientation, their gender identity or expression, or to lessen their same-sex desires. This is often referred to as reparative therapy, or sometimes sexual orientation change efforts. So, you know, these names are all sort of misnomers because we're not really talking about therapy, we're talking about psychological abuse, and it doesn't actually convert anybody or repair anything. So these terms are all not perfect. I think what we've chosen to use is conversion therapy because it's not only inclusive of both sexual orientation and gender identity, but it's understandable. The broad community understands what we mean when we say conversion therapy. So when we talk about conversion therapy, we're talking about practices that include both aversive practices, which means practices, you know, that involve like pain or nausea to stop someone from engaging in what's deemed to be a negative behavior, and also talk therapy, which is the more typical type of therapy when you go in and speak with someone about your issues and you basically talk the issues out. And so the problem with talk therapy regarding conversion therapy is that it often reinforces negative cultural stereotypes about LGBT people. So it takes all the negative things about LGBT people in society and sort of reinforces those and uses shame and stigma in order to try to change people, which can be incredibly damaging. I've heard stories of survivors of conversion therapy, for example. I know one person who was basically told that he was the only gay person left, that everyone else had died of HIV, and that if he continued in his lifestyle, that he would definitely die of AIDS as well. So, I mean, that's just an example, but those are the sorts of things that definitely not therapeutic. So one question you may have is, well, didn't this practice die out in the 50s? Why are we talking about conversion therapy? Does this still happen today? And the answer is yes, it does. Unfortunately, it really does fly under the radar. When people undergo this sort of therapy, it's usually coded as something like, just normal psychotherapy to address things like anxiety, or it's coded under normal therapeutic practices, so nothing differentiates it as conversion therapy. So it's hard to understand, how much conversion therapy is actually happening in the world and how we can spot it. It's hard to determine its prevalence. Some researchers, including Dr. Caitlin Ryan from the Family Acceptance Project based in California, have estimated that up to 1/3 of LGBT young people face some form of effort to change their identity, which can include conversion therapy by a licensed mental health practitioner. And this is, she identifies this as a form of family rejection, which we know can be extremely damaging for LGBT young people. Youth who face family rejection, for example, are at much heightened rates for suicidality, for homelessness, for drug use, anxiety, and depression. So just to give you an example. All right. So I want to emphasize also that conversion therapy is not an accepted medical practice. Every reputable organization, medical and mental health organization, has rejected conversion therapy. I could produce a list if anyone wants, about 7 pages of just one organization after another just rejecting this practice. So why does it still happen if everyone rejects it? Well, the problem is, regulations and professional rules haven't really kept up with the reality of the profession in this instance, and there's still a lot of stigmatization and discrimination against LGBT people in our society. And so people feel like we can continue to offer this practice. I just have 2 examples here, the American Medical Association and the American Psychiatric Association, and their statements against conversion or reparative therapy, talking about the risks such as depression, anxiety, and self-destructive behavior. So what can we do to stop this? Well, we've seen more states tackle this at the state level. So far, 3 states, 2 states in DC, have passed legislation to protect young people from conversion therapy. I live here, and I consider it a state, so I'll just say that. So California, New Jersey, and DC, and this has just been in the last several years. California passed their law in 2012, New Jersey passed theirs, I think, in 2013, and DC passed it at the end of last year, 2014. So these are all relatively new laws, and the way that they work is by restricting licensed providers. So anyone who has a state license to perform medical or mental health counseling or treatment basically bars them from conducting conversion therapy on youth under the age of 18, so only for minors. So I often ask, why is this important to protect minors? Like, what's the difference between minors and why would we not want to, how does this affect minors more negatively? Well, the answer is there's really three answers to that. One, minors are often less protected from coercion. They simply don't have the ability to make medical decisions for themselves in their environment that they live in, and so they can be subjected to conversion therapy against their will. Two, LGBT young people are often in a phase of identity development, so they're still trying to identify themselves and what it means to be LGBT, and are they, or are they questioning? They're going through this whole coming out process, and so it can be especially damaging to have all these negative stereotypes about LGBT people reinforced. It can cause them greater damage overall. And lastly, they're often dependent on other people just for their daily, life and sustenance, and therefore, even if they're not, they sometimes feel like they're forced into conversion therapy just to satisfy the people around them. So those are really the reasons conversion therapy, and we have to protect minors from conversion therapy especially. Although 3 states have passed these bills, there are 18 other states that have introduced similar legislation this year, and there's a list right here. Some of these are already dead, the legislative sessions, and a few states like Virginia has already ended. I think we cut off, no, we have them all there. However, some states might very well pass conversion therapy bills this year, so we're working on that across the country with partners like the National Center for Lesbian Rights, and also state-level partners like One Colorado, for instance, which we work with very closely on this legislation in Colorado. So that effort is ongoing. At the federal level, there has been a resolution introduced by Representative Jackie Speier for the past 2 Congresses called the Stop Harming Our Kids, or SHOC resolution, about conversion therapy. It has not yet been introduced in this Congress, but I understand it will be in the future. And what it does is it basically lays out a lot of the statements we've been talking about from mental health and medical professional organizations, talking about how this is a dangerous practice that's not acceptable, laying out the risk factors, and talking about how conversion therapy is just not an acceptable medical practice, and then encouraging states to basically take up and enact legislation to protect young people from this practice. So that's the SHOC resolution. Earlier, I guess last year, there was a successful petition to the White House after the death of a young transgender person named Leila Alcorn, who had undergone conversion therapy and then she died by suicide. Especially when we're talking about the death of a young person by suicide, it's not appropriate to directly link it to a cause. So, there's usually many different factors involved, but in this case, the person did undergo conversion therapy and then died by suicide. So a lot of people put together petitions in order to sort of protest against conversion therapy. And this successfully qualified with the White House. It received over 100,000 signatures, which means that the White House will, according to their rules, issue a response. And so that has not happened yet, but we're expecting it to happen in the near future. And finally, thinking about how federal agencies can sort of address conversion therapy from the federal level have identified a few different avenues. One is for federal agencies to look at what federal funding might go towards conversion therapy. And some obvious avenues are through HHS, thinking about Medicare and Medicaid funding. And as I mentioned before, it can be difficult to identify exactly what reimbursement is for conversion therapy. Yeah, because of the coding issue, but there might be other ways. Right now there's not a clear prohibition either, so there might be ways, and what we've done is asked HHS and other applicable federal agencies to consider this issue and think about how they can examine any funding streams so that we can sort of narrow or restrict those funding streams. And that's not just HHS, there's other agencies as well, including DOJ, the Administration on Children and Families, HUD, and the VA, all of which spend money on things like shelters, medical benefits. Sometimes young people, when they're put into a shelter, they have access to a shelter. Sometimes those shelters do have refer those people to conversion therapy. Sometimes it's part of, for example, if a young person is accused of a crime, it might be part of a diversion program. So some diversion programs, especially for sexual offenses, might refer a young person to conversion therapy. And of course, we think that's entirely inappropriate, and so that might be an avenue that we can also restrict. Another area I want to highlight is family acceptance. So I mentioned Dr. Caitlin Ryan's Family Acceptance Project earlier, and I sort of compare family acceptance as the opposite of conversion therapy in a lot of ways. We know that young LGBT people that come from accepting families have much better medical and lifelong sort of outcomes. And so, if we can encourage acceptance as an appropriate response to a young person coming out, rather than sort of rejection or exposing a young person to these sorts of practices, then that's really beneficial. I think it's really important to keep in mind that when a family subjects a young person to conversion therapy, they're usually trying to help that young person. They think that this is being LGBT is a bad thing. It's dangerous. I don't want my child to be subjected to that or have to undergo an unsafe lifestyle. And so they basically are trying to help their child overcome what they see as an issue, not understanding all the outcomes and it's a sort of a stigmatization against LGBT people in our culture. And not understanding all the negative outcomes of subjecting a person to conversion therapy, they might think it's a good idea in order to help their child. And so by promoting family acceptance, we can sort of change that narrative. The Substance Abuse and Health Services Administration, or SAMHSA, released a practitioner's guide on the importance of family acceptance for providers, entitled Helping Families to Support Their LGBT Children. And so we recommended that other agencies, such as ACF and ED, produce similar materials and integrate family acceptance principles into their programming. And lastly, we need additional research on conversion therapy. It's a practice that is, we just don't know a lot about it because the practitioners sort of fly under the radar and hide. And there's no sort of assessment like, there's been some research by the APA sort of cataloging all the research around conversion therapy and showing that it's ineffective. However, there's not been a lot, for example, about transgender young people and the effect on transgender young people, and more about family acceptance and rejection or the prevalence of conversion therapy. So additional research from agencies like NIH would be very helpful in this area. And it's important that it's done in a responsible way, of course. We can't have two groups, one is subjected to conversion therapy and one's not. That's not responsible. So it would probably have to be retrospective, but still it's important that we get some research on this important area. And so with that, I will end. Thank you so much.
I'm observing what an interesting program, not to be, it's so interesting how many areas have so much connection between trust, transparency, and truth, and so much work to be done that may not be transparent. So next I'd like to welcome Nick Martin, who's a Special Assistant in the Office of the Secretary of Health and Human Services.
Hi everyone. Thank you all for coming today, and thank you Chris and the Coalition for inviting me. My name is Nick Martin, and I work in the Office of the Secretary of the Department of Health and Human Services. I, along with my colleague Brett, who is to be here, handle the external engagement with the LGBT community. And I first just wanted to start by framing the discussion and talk about the administration's commitment to the LGBT community. This president, far and away, has done more for the LGBT community than in the past. We repealed the discriminatory don't ask, don't tell policy, allowing for gays and lesbians to serve in the military. We ended the legal defense for the Defense of Marriage Act and fully support legalizing same-sex marriage, and required hospitals to allow visitation rights to LGBT patients. The administration has a long-standing and deep commitment to advancing LGBT health and well-being. We've worked to put an end to discrimination in HHS programs. We recognize the vital importance of collecting LGBT data to help end health disparities, and we'll continue to push for to fill the gaps in LGBT health research. And I sort of just want to start by talking about where we are today and what we've accomplished so far. First, on the non-discrimination front, we are actively working on a proposed rule to prohibit discrimination based on sexual orientation and gender identity and services to patients in Medicare and Medicaid, participating hospitals and critical care hospitals, critical access hospitals. Secondly, improving health data on LGBT populations. We've heard a lot about that today, and a number of our operating divisions are adding questions about sexual orientation and gender identity to their surveys. That includes the Centers for Disease Control, CMS, the Food and Drug Administration, the Substance Abuse and Mental Health Administration. And thirdly, we see outreach to the LGBT community during our open enrollment period as one of our big priorities. Recognizing that LGBT Americans are disproportionately under and uninsured, we see working with our partners, especially with How to Enroll and our other key stakeholders, is vital to getting LGBT Americans insured. And the reasons for that, as we all know, LGBT Americans and their families are disproportionately likely to live in poverty, to be uninsured, and to face substantial barriers to quality health care. And that includes refusal of care, substandard care, inequality, inequitable policies and practices, and exclusion from health outreach and education efforts. And as a result of all these factors, the LGBT population experiences significant disparities in health indicators such as higher rates of tobacco use, obesity, exposure to abuse and violence, mental and behavioral health concerns, and HIV infection. So that's sort of where we are right now, and I want to look forward now and what the priorities of the department are. As I mentioned, the department's actively working on a rule that would end discrimination towards sexual orientation and gender identity in Medicaid and Medicare participating hospitals. We hope to have something out on that soon, and very much welcome open comments from our stakeholders. Funding research on LGBT health inequalities. NIH will supplement existing research projects that expand the knowledge base concerning health inequalities for sexual and gender minorities, as well as release a strategic plan for sexual and gender minority health research. And we can't highlight enough our commitment to getting more and better access to LGBT health data. As I mentioned, some of our operation divisions are already collecting data on those surveys, and we hope to expand that going forward. And so on the transparency front, which I think is what we really want to talk about, the transparency in healthcare and in all of our work is very important to Secretary Burwell. And so just to give a couple examples on a couple different levels, during this open enrollment period, last year we had given monthly data on where we were in the enrollment process. This year we are also adding weekly snapshot data to sort of track the progress and release that to the public and to our stakeholders. And sometimes drilling that down as much as zip code and city level data. And for our big enrollment partners, this is critical for them in having them understand where best to target, where are big holes in the enrollment process this year and where they need to be going forward. On the consumer experience, the Affordable Care Act made the individual insurance market more consumer-friendly by increasing the amount of transparency into provider networks and plans. Consumers can easily compare side-by-side plans, dramatically increasing competition amongst all the healthcare providers. Healthcare.gov links directly to a provider's network directory, enabling consumers to see what doctors are in network and what doctors are accepting new patients. And finally, one of our big highlights is our LGBT Issues Coordinating Committee. Then Secretary Sebelius started this in 2011, and it involves representatives from all of our operating divisions, all of our different departments, coming together and working with our stakeholders very actively so we understand what their health policy concerns are and so that we can have an open discussion on where we are with things and what we need to do going forward. This committee issues an annual report, usually around the end of every year. So last year came out in November, and we're expecting the same timeline this year. The annual report's available at hhs.gov/LGBT, along with a bunch of other resources. And that's pretty much all I have today. Thank you.
Finally, I'd like to welcome Christopher Cannon, who is the Senior Manager of the Coalition for LGBT Health, and also thank Christopher since he put today's program together, and he's going to give a brief highlight of research that will be launching this week on an area he's going to highlight for you.
Thank you, Brian. So yes, the Coalition, as part of the LGBT Health Awareness Week and our mission for the coming year, is working to put together a nationwide survey on the state of LGBT health. And we're looking to do this in a multi-perspective way where we want to reach the consumers, providers, and health system administrators to really get the full view of what our health, public health system is out there. And the reality very much modeled after our partner, one of Colorado's report, who will be helping us with this report, and many up, as Kevin will probably be helping as well, his health department. So we are working on this, and we will be getting this out the door as quickly as we can and getting a report together this year. Again, this will just be identifying access to services, utilization of services, the barriers and challenges, both from the healthcare system side and the personal individual side, because there are barriers on both, and the care delivery modifications that are possible. And with that, we can say thank you, but we will open it up for questions at this time.
Hi, I'm Cranston from the American Psychological Association. I've been sitting here thinking about all this wonderful stuff. I'm a researcher by trade, and of course I'm very much in love with data, and just full of questions around the data set that you've gotten and as such. But I've been thinking about any potential downsides to trust, transparency, and truth. And one that comes to mind off the top of my head is where this might get somebody in trouble, is around HIV criminalization in some states where it's illegal for HIV seropositive people to be sexually active, essentially. I'm just wondering, are there any other risks that you see to these three keys, and what ways can you mitigate those risks?
I mean, I'll just address the one issue you bring up, and we've had some extensive conversations, and I know NASDAQ convened a national discussion of this very issue, because we are evolving the use of surveillance data in order to do a better job of making sure individuals with HIV are engaged in care and being supported. So there is many of the historic legal protections surrounding HIV data have been lowered, even in states like mine, which have very, very strict protections, in order to do a better job of supporting care. But it did come at the risk in those jurisdictions, in those states that have criminalization laws. So it's really been the position that as you advance your data quality and extent and what you have in publicly identifiable data sets, or not identifiable, you often need to put legal protections around those data sets in terms of personally identifiable information. You have to look at the criminalization statute simultaneously. And frankly, I think it's a barrier for jurisdictions that still has those laws on the books to be able to move forward with the advancing use of surveillance data. And so, you know, we in some way anticipate a lot of that, but we've never had those statutes in Massachusetts, the criminalization statute, but there certainly have been efforts to use surveillance data in criminal prosecutions of a variety of natures. And so having strong public health laws and other statutes surrounding the data sets that do prevent them from being subpoenaed or from being identifiable for other than the intended uses, I think is an important legal consideration surrounding this work.
I'll just add that also right before we started, literally Leo and I were chatting about the need to coordinate more advocacy on criminalization and its connection not just to data collection, but to advocacy work and partnering with those who are leading those efforts to make sure that we're addressing that, so that ideally, we're working on, parallel tracks and building the protections that Kevin mentioned and doing the necessary advocacy around it.
Yeah, so it's kind of like the catch-22 where you need the data to drive policy change, but you can't change the policy without the data, so you need it, and that's why having that confidentiality policies in place is really important, as well as most of the surveys, it's optional to answer any demographic information, so gender identity, sexual orientation, as race, class, things like that. So those are all optional questions that an individual can opt into answering or not. And that's also an important piece of these surveys, and making sure people know that that's available to them, and they can choose not to answer certain questions if they fear some kind of retaliation in the end.
If you have an NIH research grant, you can apply to NIH and get what they call the COC. COC means Certificate of Confidentiality. If you're collecting very sensitive data from the participants, and what the COC will do is it will protect you and your subjects, and those data cannot be subpoenaed by the court. So make sure that your principal investigator apply for that certificate of confidentiality.
Yes, I hear everything you say. Thank you for what you are doing. But I didn't hear anything about related with documented populations. I know states like Massachusetts especially has a documented population from all over the world. But in the South we have mostly a lot of documented population from the Latin American countries. And it's not taking, that population normally is not taken into consideration for any kind of statistics, or any kind of price or services, or absolutely almost anything.
I'd love to respond to that. I think actually it's a great example that didn't come to mind immediately from your question. In many ways, we collect a great deal of information about people's immigration status and documentation status, and we hold it with great trepidation, because frankly, the political realities surrounding attitudes towards, newly arrived and long-term immigrants, refugees, and individuals who may or may not be fully documented at a given moment in time, because it's a dynamic reality, because of a desire on many parts of the populace to feel that individuals who are not U.S. born or individuals who are not fully documented don't deserve public resources. We often do not put forward the data that we do have because it becomes a lightning rod for some of those political forces. And at the same time, it disables us from making the very arguments we want to make around residents are residents, and particularly in public health. The organisms and disease entities that we're concerned about make no differentiation between people's legal status, at a given moment. And so we actually find ourselves constantly making a decision, do we highlight or don't we highlight what is often disproportionate impact on undocumented individuals, LGBT and otherwise. And we actually would appreciate some guidance on that. When is it worth the political risk to highlight? And when are we actually doing a greater disservice by not addressing?
In a way, because a lot of the undocumented population, especially the Latino, that's what I'm Latino here, is we have like a double stigma.
Yeah.
One stigma because we are undocumented, the other stigma is because we're gay. So, and also every state in the country has different laws, and they keep different the undocumented population. In the South, mostly, they need a proof of residence. And you cannot, the only proof of residence you can get is a state card or a driver's license. And you cannot get that if you are undocumented. So it's like,
We've recently expanded the ability to get a driver's license regardless of documentation status, but I know that's far from universal. Very important issue.
To add what he just mentioned, hi, my name is Alison Gill. I work for La Clínica del Pueblo. We mainly work with immigrant population, undocumented, here in DC since late 1980s. We provide free services to them initially, and now we're a federally qualified community-based health center. We provide even if they are undocumented, we provide services. Either through the service, through donations, even through some grants funding, also through the federal government. And we do collect data also, as you mentioned. But the issues that we have, in order to put it out there, we have to be associated with an academic institution, and some of the institutions are not that interested on collecting that data from what you just mentioned. That issue of like, what if we put that information out there, is it going to be beneficial for the other causes that we're fighting for? But, I mean, the populations, the immigrant population that we have here, they don't live in the ball. They interact with the other population, general population, obviously. So it's a public health issue and should be addressed. And especially for the trans community, and we see it from Central America, because they've been granted, in some instances, they've been granted asylum because of their being persecuted and being killed in Central America. So they come here to the sea area mainly. So it's a catch-22 situation. That will be do, that will be done, but it's still a public health issue, and I think it should be addressed, and that data that we can collect, we can use it. I mean, we do collect data, and as you also collect data, I'm sure that in Colorado also collect data about the Latino immigrants and undocumented too. So that should be put out. Someone will be breaking off to put some light into that.
I want to do a shout out to HHS, two programs, one, the 330 Community Health Center program and the Ryan White CARE Act, both enable and allow the expenditure of federal resources on individuals independent of their documentation status. And I'll say for Ryan White, it's been a major provider of health care for gay and bisexual men since 1990. And without it, we would not have the successes we've had in fighting the HIV epidemic in our jurisdiction. It really is those Ryan White resources that make it possible.
Yeah, but I'm sorry, I agree for everything you say, but there's still some states, as I mentioned earlier, that every state has different laws.
Indeed.
And even to provide Ryan White sometimes
That's
have
true.
problems, even to provide services if you are a fair qualified community health center, still, because we have to have some proof of documents. And talking about that part of providing holistic health to the LGBT community, nobody mentioned about a primary need, that is housing. Housing is something really important, that especially in the elderly population is becoming a big issue in the LGBT. Nobody wants to live with us, and we don't want to live with them.
So we are a little beyond 4 o'clock. If there's any other questions, we can take them after, but at this point.
I also we are going to put the survey tool out for input, and I think it's important that there is a section about, under the state of LGBT health, that we look at the challenges of data collection and also the need for data confidentiality, or how the data are used, and that the assumption isn't made that everything collected is just made public, and that it will also, I think to Leah's point, help us document what we need to be able to prove, even if it's to prove to begin with, that there are significant barriers to collecting these data and the way that it can be used against people in criminalization context or otherwise. The other thing that we will look at is, and there are certainly parallels and differences here, but HIV testing a decade ago and written consent, informed consent, and confidentiality and stigma and everything related to HIV testing that certainly we still have to address today, but what we've learned from that and how policy can catch up with data, and with one of the refrains of cities or locations that said, well, we don't address HIV because there's no HIV in the area, and we said, well, there's no HIV because you're not testing for it. And so, broaden it to other chronic diseases and to LGBT health issues across the board. We'll look at that as well. But we very much want to float that by for input so that we can make it as comprehensive as possible, realizing it's only one of many tools out there. I also want to thank Brad and everyone that helped Chris put this together today. And we will have it on our website, as well as yesterday's webinar, which actually had so many people, we couldn't accommodate everybody on the webinar. We went over 500 people, and so the joy of technology. But it was about LGBT health centers and a variety of trusting relationship discussions in LGBT health centers. So that's worth looking at on the website as well, and certainly more to come throughout the year. But thank you to the panel and to Christopher and Brad and everyone for being here today.
Thank you.